We are live.
Hello, good evening, everyone. On behalf of ARC, I welcome you all to the 72nd episode of the AIOS ARC PG Teaching Program. So, this is an initiative of the new team of the Academics and Research Committee. And in this PG Teaching Program, every week we cover a topic that is not usually covered by other PG Teaching programs. So every week we either have a didactic lecture, we have interpretation of common diagnostic modalities, a journal club, and this week we have two short case presentations. So these PG teaching programs have become extremely popular, and every week we have a viewership of around 2,500 to 3,000 PGs who are watching us. And this platform will give you also, it'll for the PGs who are presenting, it'll give you a simulated situation that you'll be facing in your exams. So, and for the others, it's a very good chance to, see the kind of questions that the examiners ask. So today, the presenters for the cases are Dr. Shikha Kumari, who's a second year junior resident at the Grant Government Medical College and Sir JJ Group of Hospitals, Mumbai. She has been mentored by Dr. Sujata Chahande, who's professor and head of department at the Grant Government Medical College and Sir JJ Group of Hospitals, Mumbai. So a very warm welcome to both of you. The second case presentation will be by Dr. Saurabh Tripathi, who's a junior resident in the Department of Ophthalmology at Narayan Medical College and Hospital, Jamuhar Sasaram, Rohtas. And he has been very ably mentored by Dr. Amresh Kumar, Associate Professor, Department of Ophthalmology at the Narayan Medical College and Hospital, Sasaram, Rohtas. So looking forward to your presentations. Now, we're very thankful to both the young budding ophthalmologists and their mentors who have, who've come here today and are going to be with us. Apart from that, a very special thanks to the examiners. So we have a very stellar galaxy of examiners with us. We have Dr. Sudhir Salhotra, who's the director of the Palampur Rotary Eye Foundation, Palampur. We have Dr. K. Shrikant, who's professor and director of ophthalmology at the Mahatma Gandhi Medical College and Research Institute, Pondicherry. And we have Dr. Kamaljeet Singh, who is professor and head, Regional Institute of Ophthalmology at the MLN Medical College, Allahabad. So a very warm welcome to you all. And we're very thankful to you for sparing time to be with us. And I'm sure your inputs and your questions are going to go a long way in helping these PGs to forge their way forward. So thank you so much for joining us this evening. Also, to all the PGs who have logged in, we have a chat box, so you can keep your questions coming. And if there's any question or query, you can put it, or any comment, you can put it in the chat box. So with that, we start. I request Dr. Shikha Kumari. She'll be presenting a case of posterior polar cataract to kindly share her slides. And to the examiners, please feel free to interject at any point. If you have a question, you can interrupt in between and ask a question. So over to you, Dr. Shikha, and all the best. Dr. Shikha is a second year junior resident, and let's see how she feels the questions. So over to you. Yeah, we can see your slides.
Yes. Good evening to all the respected teachers, everyone. I am Dr. Shikha Kumari, second year junior resident.
Dr. Shikha, your volume is a little on the lower side. Could you turn up the volume? Or if you could move closer to the microphone.
Is it fine, ma'am?
Better
Hello?
now. Yes.
Yes, fine, doctor. Please continue.
Yes, it's fine.
Okay. I am Dr. Shikha Kumari, second year junior resident from GGMC Mumbai. My mentor is Dr. Sujata Chahande, professor and head of Department of Ophthalmology, Grand Government Medical College, and Sir JJ Group of Hospitals. So I will be presenting my case on 38-year-old male, hailing from Thane, construction worker by occupation. He came with chief complaint of diminution of vision in both eyes since 6 months, associated with difficulty in vision in bright light. History of presenting illness. The patient was apparently all right 6 months back when he developed gradual, painless, progressive diminution of vision in both eyes since 6 months, associated with difficulty in vision in presence of bright light. No history of flashes and floaters. Ocular history, no history of spectacle use in the past, no history of ocular surgery or trauma, no history of laser or injection. Family history, no significant family history. Systemic history, no history of systemic illness. On general examination, the patient was conscious, well oriented to time, place, and person with normal body mass index. BP was 130 by 80 millimeter of mercury. Pulse was 76 per minute. No evidence of pallor, icterus, cyanosis, clubbing, or lymphadenopathy seen. On systemic examination, serious S1, S2 heard. On respiratory system, bilateral breath sounds heard. Per abdomen, soft, non-tender. CNS, no focal neurological deficit. On ocular examination, no face turn, chin elevation, or head tilting. No proptosis, nystagmus, or ptosis. Unaided visual acuity in right eye was 618 on distance Snellen's chart. Best corrected visual acuity in right eye was 618 with -1 diopter, not improving with pinhole. Lid was normal, conjunctiva normal, cornea clear, anterior chamber was normal depth, iris normal color and pattern, pupil 3 mm round, regular, normal reacting to light. Lens shows dense white discoloration at posterior pole of lens, surrounded by concentric ring in bull's-eye pattern or onion whirl pattern. In left eye, unaided visual acuity was 618 on distance Snellen's chart. Best corrected visual acuity was 6 by 9 parts with minus 0.75 diopter, not improving with pinhole. Lid was normal, conjunctiva was normal, cornea was clear, anterior chamber has normal depth, iris was normal in pattern and color, pupil was 3 mm round, regular, normal reacting to light. Lens shows dense white discoloration as posterior pole of lens surrounded by concentric bull's-eye patterns. Intraocular pressure using non-contact tonometer in right eye was 16 millimeter of mercury. Fundus has media clear, 0.3 CDR, 0.3 cup-disc ratio. Foveal reflex was present, rest normal fundus. Roplus was negative. In left eye, intraocular pressure on non-contact tonometer was 16 millimeter of mercury. Fundus media clear, 0.3 cup-disc ratio. Foveal reflex present, rest normal fundus, and Roplus was negative. On slit lamp, on first picture, in slit lamp examination, we can see whitish discoloration in onion whirl pattern, and on retro illumination, well demarcated opacity can be seen. So my summary is 38-year-old male with complaints of diminution of vision in both eyes since 6 months, associated with difficulty in vision in bright light. On examination, unaided visual acuity in right eye was 618, corrected to 69 parts with -1 diopter, not improving with pinhole. And on left eye, unaided visual acuity was 618, corrected to 69 parts, not improving with pinhole. In central pupillary area, whitish dense circular onion whirl-like discoloration is seen in posterior pole of the lens. So my provisional diagnosis is 38-year-old male with both eye grade 2 posterior polar cataract. I ordered systemic investigation and ocular investigation. On systemic investigation, CBC, complete blood count, blood sugar level, ECG, renal function test, chest X-ray, and urine routine microscopy was done. On ocular investigation, biometry, keratometry, topography, OCT, and specular microscopy was done. Other differential diagnoses are posterior subcapsular cataract, focal traumatic cataract, congenital cataract, lens abscess, or lenticular intraocular foreign body. Management. We have planned this patient for phacoemulsification with posterior chamber intraocular lens. Patient has been counseled regarding risk and complications, especially posterior capsule rupture and possibility of secondary intervention needed. Peribulbar anesthesia was given, 5.5 mm capsulorhexis was done, hydrodelineation was done, and phacoemulsification done with low energy and low flow parameters. posterior capsule integrity was inspected, and foldable IOL was put. Post-op medication given, topical steroid, anti-inflammatory, and antibiotic were prescribed, and patient has been followed up for the same. Thank you.
Good evening. You have done a very exhaustive presentation, very good, complete examination you have been done. I have few questions for you.
Yes, sir.
Why there is defective vision in the bright light? This patient. Another thing was you
Yes.
said gradual loss of vision. Will it be there?
Yes, sir. Yes, sir. In progressive type of PPC, gradual patient experiences gradual loss of vision in progressive type of PPC.
Okay. But why there is a drop in vision in bright light?
Sir, in bright light, the pupil gets constricted and the opacity is the center, so it obstructs the light to enter.
Correct. And what's the explanation for no improvement with pinhole?
Yes, sir. Because the opacity is in center, therefore, with pinhole also it is not improving fully.
You can instead of saying center, you can use the same term nodal point.
Nodal point.
So any opacity in the nodal point is going to cause no improvement in the pinhole, or like what you said, in bright light, when there is pupillary constriction, when the light passes through the nodal point, it is going to cause a drop in vision. Inside the room, the vision will be okay. 618 you said, no, 69 it is improving. But the
Yes,
same vision will not be there in the bright surroundings. Fine.
Yes.
Another thing, how do you differentiate posterior polar cataract from posterior subcapsular cataract?
Yes, sir. Posterior polar cataract is well demarcated, and posterior subcapsular cataract is diffuse, has diffuse margin. And in investigation also, we can, in ASOCT, we can demarcate that it is posterior polar or posterior subcapsular. Posterior subcapsular is just beneath the capsule.
Yeah, correct. Your explanation is correct. Actually, it will be very diffuse, unlike a posterior polar cataract, which has got a very specific morphological feature. Very good.
Dr.
And it has,
Kamaljeet, sir?
Yes. Supposing the patient does not agree to surgery, what would you advise to this patient?
does not agree to?
Does not agree to surgery. He
Yes, sir.
says that I'll wait for some maybe 6 months. Then what
Yes.
management will you do for this patient? And what advice will you give?
I will prescribe glasses for this patient.
Hmm.
I will prescribe glasses for this patient, and advice for every 3 or 6 monthly.
Okay. See, if the patient does not agree, then I always tell these patients not to drive the vehicle. Because when you are driving the vehicle, you get the bright light and you will not, when the pupil constricts, you will become almost blind in bilateral cataracts. So the driving is absolutely not allowed, number one. Number two, in daytime, we can give dark glasses because that keeps the pupil slightly dilated and patient is comfortable. So these two things can be done for a posterior polar cataract. Secondly, in anterior segment OCT, what do you see for posterior polar cataract?
In ASOCT, we can see the posterior capsule, whether integrity is maintained or not.
Yes, that's very, very important point. Because if you do a anterior segment OCT and slightly go slightly deeper into the lens, you can get a good view of the posterior capsule, and there this important thing can be seen whether the posterior polar cataract has a pre-existing defect
Right.
or not. And when you are doing surgery, what care you take,
Yes, sir.
what important care you take to intraoperatively.
Yes, sir. Intraoperatively, capsular access should be at least 5 mm or more,
Mm.
as it will, if the capsular access size is less, it will create pressure on the posterior capsule. We do hydrodelineation instead of hydrodissection in
Right.
these cataracts. Yes, sir. And closed chamber technique is followed.
Mm.
And before removing any instrument from anterior chamber, we have to put visco, dispersive visco.
Mm.
And
You have already told about low parameters that you use for
yes, sir, low parameters.
low parameters.
Phaco,
And you should have your good friend vitreoretinal surgeon along with you, because sometimes if the defect is there, then you have to manage the vitreous also. So
yes,
you
sir.
should be careful about this, and you should keep all the IOLs, a non-foldable IOL, a three-piece IOL, and the normal IOL that you are trying to implant. So these three things are very, very important. Otherwise, many a time you are not able to implant the lens if the defect exists. And supposing you see a defect, what do you do then?
If we see pre-existing defect, then we will first put a dispersive visco to
Mm.
avoid anterior hyaloid rupture or vitreous coming in anterior segment.
Very good.
Yes, sir. And we can
And
also do posterior capsular CCC.
वो तो उसमें अपने आप ही हो गई है,
Yes, sir.
वो तो अपने आप ही हो गई है ना, तो you don't need to do that.
Yes, sir. मतलब
Okay,
to
so
avoid the extension of the
that is
margin.
done for the PCR that we, because if mostly when we have a posterior polar cataract, the defect is absolutely round. It's like posterior capsular access most of the time. So you don't need, but the other question is if the cortical matter is still there and you have seen the defect, then what will you do?
Yes, sir. After putting dispersive visco, we can aspirate the cortical matter with low flow, like in bottle height should be 50 centimeter approx,
Very good.
and we can aspirate the rest
Cortical.
cortex.
In dry, you can do it in dry mode also. Supposing you are doing SICS or something, then you don't put fluid, because if the fluid goes inside, it goes into the vitreous, and vitreous swells, and the chances of vitreous loss are there. So you keep on putting your viscoelastic inside, and with the help of that, you can do a dry aspiration. So thank you so much. Very nicely presented.
Thank you.
Dr. Tinku, I would like to comment. If you have seen the vitreous and there is still a cortex remnant, you can even use your cutter at the aspiration mode. You can just aspirate the remnants of the cortex, and if vitreous is coming, you can do a little bit of vitrectomy. But if vitreous phase is intact, you just remove the cortex and place the IOL. Even your cutter does wonder. But as Dr. Kamaljeet sir has rightly pointed out, if you do the SICS with the dry aspiration, you can just remove it. I have one question for you. You made the diagnosis of type 2 posterior polar. Why you made the diagnosis of type 2? And what is the significance of type 2?
Yes, sir. Based on Daljit Singh classification, I have made the diagnosis as can I explain all the grades of
Yeah.
yes, sir. Grade 1 is associated, grade 1 PPC is associated with the PSC. Grade 2 PPC is, grade 2 is only onion whorl appearance, not associated with any other opacities. Grade 3 is PPC associated with the Daljit Singh spots sign. On the edges of the PPC, whitish spots can be seen, which indicate the weakness of the posterior capsule. And grade 4 is all above 3 types associated with nuclear sclerosis.
So what is the significance? Grade 2 means you don't have the weakness and the surgery is relatively safer. But if it is grade 3 and 4, then you have to be careful. But in these cases, as rightly pointed out, ASOCT has the significance. If you could see the defect, so that is one of the important aspects. So as a surgeon, what would you advise? Would you like to go for an early surgery or would you like to wait in these type of cases, and why?
Sir, I would advise early surgery, as after waiting, it will convert to grade 3 or grade 4, which is more difficult to handle.
Good. So as early as possible, if your patient is convinced you should take up for surgery, once the nucleus is softer, you can easily take out the things very easily and not land up in the problems. So what is the bilateral incidence of PPC?
The bilateral incidence, yes, sir. Bilateral incidence in PPC is approx 50 to 55% in 50 to 55% cases.
Slightly more. It is slightly more. In your case also, I think it was bilateral. It is around 60 to 80% cases you do see the bilateral. And what is the percentage of PCR in these type of cases?
Sir, in 35% cases, PCR happens in PPC.
It again depends. Now with the better techniques coming up, now the incidence is dramatically coming down. Only in the pre-existing cases, as we started these surgeries, most of these cases we used to have PCRs, but with the latest parameters and fluidics controls coming up, now the incidence is coming down dramatically.
Yes.
But the books do quote the incidence of around 30-35% as a PCR. One more question is, why this typical appearance of onion peel or bullseye? Why that typical appearance is there? And you distinguish between a posterior polar and the PSC. Why that typical appearance, do you think?
Sir, in progressive PPC, we mainly find this onion wall appearance. With time. Hello.
So what is the pathogenesis? I want to know about the pathogenesis.
Yes, sir. It is caused by the persistence of hyaloid artery.
Persistent hyaloid artery, okay.
Yes, sir.
So what do you call that if there is a small spot left in the interior lens, interior part of the hyaloid artery, if it is left, it remnant is there. What is that term?
Mittendorf dot.
Good. Good. And what about the posterior? On the disc you see? Okay, you just focused on the cataract only. Okay. We call it some papilla. Have you heard the name of Burr?
Mr.
Something? Yeah.
Yes, sir, but Mr.
Yeah. Papilla. So these are the remnant. It is basically, it could be autoimmune, autosomal dominant, or they can be sporadic. It is the abnormal developmental abnormalities. Basically, the lens fibers development is defective, which leads to that particular type of onion peel or a bullseye cataract. I think from my side, it's all over. Thank you so much for your nice presentation, and you answered abruptly and very aptly. Thank you so much.
Thank you so much, sir.
Thank you so much. Any other examiners, if you want to ask any other question? No? So, Dr. Shikha, I must compliment you on the confidence and the correctness with which you fielded all the questions. Considering you're just a second-year resident, I think you did a wonderful job. Hats off to you.
Thank you so much, ma'am.
And I would also like to congratulate her mentor, Dr. Sujata Chahande, who's done this excellent job of teaching and training her. Dr. Chahande, are you there?
Yes, yes, very much.
Yeah, hi.
Hi.
So, Would you like to just, comment on some common mistakes that PG makes, like while you were in the process of mentoring her? Any tips for our PGs? If you would like to give a few quick tips while they're presenting a case.
Well, I mean, I usually tell all the PGs in any case, not just PPC, that it's like driving a vehicle. You should know when to jam the brakes, and that should be a very graded thing, not a very sudden jerk that one usually gives on the car. Likewise, one needs to be that careful. So, when in doubt, better to stop, pause, take your time, and move ahead then. So, I think a good Rexus is something which is prerequisite for any surgeries, because once your Rexus margin is intact, then you can manage whatever cases that are possible, either lenses that you want to put in, whether it's a sclerofixated or you want to use a claw lens or you want to put in so that is the key point. So practice the Rexus first. Once you're done with that, I think most of the cases can be managed effectively in order to do it. Yeah.
Thank you. Thank you so much. And congratulations once again for the
Thank
great
you.
job.
Thank you.
And with that, we move on to the next short case. So the next case will be presented by Dr. Saurabh Tripathi. And his case is also an interesting case of cataract. He's been mentored by Dr. Amresh Kumar, who's an associate professor in the Department of Ophthalmology at the Narayan Medical College and Hospital, Sasaram, Rohtas. So over to you, Dr. Saurabh. Please share your slides.
Good evening, everyone. I am presenting a case of sunflower cataract. I'm very thankful to my mentor, Dr. Amresh Kumar sir, who is Associate Professor in Department of Ophthalmology in our college. So my case is, patient name is Jagat Kumar. He is 28 years old male, resident of Aurangabad, Bihar. He is the daily wage worker by occupation. Chief presenting complaint: blurred vision in both eyes, right eye more than left eye, for past 8 months, which progressively decrease in vision associated with glare. History of presenting illness. The patient was apparently asymptomatic 8 months back when he developed blurred vision in both eyes, right eye more than left eye. The symptoms have been insidious and worsening gradually over the last 8 months. His complaints are predominantly related to glare, which increased in bright light conditions. Negative history. There is no episode of any ocular pain, redness, photophobia, or halos. There is no history of trauma or systemic manifestations such as headache, dizziness, tremors, altered mood, or hepatic dysfunction. Other history, past history, no history of drug intake, no history of environmental or occupational exposure to UV light or toxic substance. Medical history, no known chronic medical condition, no history of diabetes, hypertension, spectacle use, or previous ocular disease. Surgical history, no history of any surgery in past, uh, no history of any surgery in past. Personal history, he is on mixed diet, sleep and appetite were normal, regular bowel and bladder habits. Patient denies any history of smoking or alcohol intake. Family history is non-contributory with no known genetic disorder or similar complaint in first degree relatives. General examination, patient is moderately built and nourished, conscious and well oriented to time, place, and person. No pallor, icterus, clubbing, cyanosis, lymphadenopathy, and pedal edema seen. Vitals, temperature was afebrile, pulse rate was 74 beats per minute, respiratory rate was 16 per minute, and blood pressure was 116 by 80 millimeter of mercury. Systemic examination, respiratory system, bilateral normal vesicular breath sound heard, CVS, S1 and S2 heard, no murmur, CNS, patient was well oriented to time, place, and person, no focal neurological deficit present. Per abdomen, soft and non-tender on palpation, no organomegaly noted. Facial symmetry, no facial asymmetry noted. No abnormal head posture noted. Ocular examination, visual acuity distance in right eye was 6 by 24. With pinhole, it was improving to 6 by 18. Near vision was N12. In left eye, visual acuity was 6/12. With pinhole, it was improving to 6/9, and near vision was N6. Lids were no abnormality detected in right eye and left eye. Conjunctiva was within normal limit in right eye and left eye. Cornea was not transparent, no vascularity. Greenish brown pigment deposition was present at the level of descemet. It was circumferential and suggestive of KF ring in right eye and left eye both. Anterior chamber, it was normal in depth, VH grade 4, Von Herry grade 4, and content was normal. Iris was normal color and pattern. In right eye pupil, pupil was normal in size, around 3 millimeter. Shape was normal and normally reacting to light, both direct reflex and consensual reflex. In left eye, it was normal in size, shape, and normal reaction to light. On lens, golden brown anterior subcapsular opacity in the central region was present with stellate pattern radiating from the center, resembling the pattern of sunflower petals, suggestive of sunflower cataract. In left eye, it was also similar finding was there, but it was slightly less pronounced. Fundus examination done with slit lamp biomicroscope with 90 diopter lens and indirect ophthalmoscope with 20 diopter lens for periphery. Media was slightly hazy due to cataractous change in lens. Disc was within normal limit. CDR was 0.3:1. FR was present. Macula was within normal limit. Vessels and periphery was also within normal limit. In left eye, media was clear. Disc was normal with cup disc ratio of 0.4:1. Foveal reflex was present. Macula was within normal limit. Vessels were within normal limit, and periphery was also within normal limit. Extraocular movement were full in all cardinal gauges. And gauge, right eye and left eye both were orthophoric. Gonioscopy was done with 3-mirror gonioscope, and posterior pigmented tympanic posterior pigmented TM seen in both right eye and left eye. Rhoplas was absent in both eyes. Syringing was done for the both eyes and patent in both. IOP was done with Goldman apprenticed tonometer at 10:30 a.m. in the morning, and it was 16 millimeter of mercury in right eye and 14 millimeter of mercury in left eye. This was the cataract which was seen in right eye, and in left eye, sunflower cataract was present, but it was but finding was not like right one. Clinical summary. A young male patient, 28 years old, came to a comprehensive ophthalmology OPD with complaints of blurred vision in both eyes for past 8 months with a progressive decrease in vision associated with glare. On examination, right eye showed KF ring along with characteristic sunflower cataract in central region with the stellate opacities radiating from the center, resembling the pattern of sunflower petals. Fundus details were within normal limit. In left eye, KF ring was present with cataractous changes which were less pronounced. Fundus was within normal limit. IOP was done with GAT and it was 16 millimeter of mercury and 14 millimeter of mercury in right eye and left eye respectively. Provisional diagnosis. The presence of KF ring bilaterally along with golden brown anterior subcapsular opacity with stellate pattern right eye more than left eye suggestive of sunflower cataract. The pattern of the presence of this pattern in absence of trauma or any other obvious ocular pathology suggests the possibility of a systemic etiology being bilateral, most notably Wilson's disease. Differential diagnosis, it can be nuclear cataract, but it is less likely due to the specific pattern of cataract which has been observed. Traumatic cataract, unlikely due to absence of any trauma history. Congenital cataract can be less probable because age of onset and pattern of opacification was quite specific. Metabolic or genetic cataract possibilities include cataract associated with metabolic disorder, especially Wilson's disease. Investigations, serum ceruloplasmin levels were done, which low level of which suggestive of Wilson's disease. Serum copper levels typically low in Wilson's disease. 24-hour urinary copper excretion test along with penicillamine challenge. Elevated urinary copper excretion is a hallmark of Wilson's disease. Liver biopsy, it is a gold standard diagnosis for Wilson's disease. And slit lamp photography, high definition documentation of cataract for further analysis. Genetic testing for ATP7B gene To confirm Wilson's disease, as mutations in this gene lead to defective copper transport. Liver function test to be done to assess hepatic involvement, neuroimaging, MRI or CT to evaluate the neurological manifestations of Wilson's disease. Example, copper deposit in basal ganglia changes. Psychiatric assessment to be done to identify cognitive or psychiatric symptoms which can be seen in Wilson's disease. Treatment is ophthalmological management. Cataract surgery indicated if the visual acuity continues to decline or significantly affect the quality of life. Lens extraction along with intraocular lens implantation may improve vision. Preoperative assessment of systemic health is required. Management of Wilson's disease, copper chelation therapy, initiation of agents such as penicillamine, trientine, or tetrathiomolybdate to manage the copper accumulation. The goal is to reduce hepatic copper stores and prevent progression of liver and neurological complications. Zinc therapy, zinc salt used to block copper absorption from the GI tract. Zinc therapy is also used in pre-symptomatic persons and in pregnancy conditions. Liver function monitoring, regular follow-up to monitor liver enzymes, hepatic ultrasound, and liver biopsy if needed. Multidisciplinary follow-up, hepatology consultation to be done to assess liver function and management of hepatic involvement in Wilson's disease, neurological consultation for screening of early neurological symptom or psychiatric assessment as Wilson's disease may present with neurological or psychiatric features in absence of overt liver dysfunction. Thank you. Thank you, ma'am, sir.
Doctor, exhaustive presentation. And what about the screening for the family members? Was it done?
So it was not done because patient was not turned up in follow-up. Sir, we advised screening for the family members also, and investigations were also not reported to us after consultation from hepatology department.
So what are the modes of inheritance in this?
Sir?
Mode of inheritance.
Sir, it is autosomal recessive disorder, basically involving ATP7B gene. Copper transport can also be affected by ATP7A gene in Menkes disease. But in our case, it is highly suggestive of Wilson's disease because of typical sunflower appearance of cataract as well as K of ring present bilaterally and in whole circumference.
Was there any history of taking copper containing foodstuff and also taking food in it can, because of leaching of copper from certain vessels, that can result in copper. Was it?
Sir, I took history for the same, sir, but copper containing food like sailfish, jellyfish, and seeds and nuts and chocolates, but patient was of very poor background and he was not using even copper vessel and food ingredients which are rich in copper. That's why
yeah, that
I think yes, sir.
Yeah, that aspect also has to be considered. Okay.
Yes, sir.
Fine. Why there is that typical appearance of that golden brown appearance or whatever?
Sir, golden brown appearance is basically due to extracellular deposit of copper in the central center region. It is subcapsular in anterior as well as posterior also it can be present. Centrally it is copper deposition which gives a golden brown look to the cataract.
Okay. He didn't have any other central nervous system affections.
No, sir. For the first time, he came to our OPD with the blurred vision, and we sent him for neurological and hepatological consultation for ruling out any systemic involvement. No systemic features was there, sir. No organomegaly was there. No hepatomegaly was there. His appetite was also normal. Icterus was also not present. Sir, dystonia, dysphagia, and tremors like symptoms were not present in the patient. For the first time, ocular manifestation was there, and we for early diagnosis and management of suspected Wilson's disease, we referred patient to the
Okay.
yes, sir.
Okay. Now, in this patient is 28-year-old, but why is near vision is only N12?
Sir, because central vision is there, and central cataract is there, and while doing near vision, pupil get under miosis. That's why central vision was affected in that eye, and vision
Ca-
was just improving to N12.
Correct. That is the answer you have to give, because meiosis is one of the feature of accommodation, and when the patient accommodates, automatically there will be drop in this vision, near vision. Correct. Good. Good.
So the other examiners, Dr. Kamaljeet sir, if you'd like to ask.
What is snowflake cataract, doctor?
Sir,
Snowflake cataract.
snowflake cataract is seen in diabetes mellitus. It is also metabolic cataract. Snowflake cataract or snowstorm cataract seen in diabetes mellitus
What
conditions.
is rosette cataract?
The rosette cataract is seen in traumatic conditions, in ocular trauma. Actually, rosette cataract also looks similar to sunflower cataract, but in rosette cataract's appearance is white opacity is there in center and look like a star, while in sunflower cataract opacity is golden brown and look like petals of sunflower, and central opacity is there. Central opacity is large and spokes are present like petals of sunflower, which are very less. And in rosette cataract,
What is blue dot cataract?
the blue dot cataract is a congenital cataract seen, sir. It doesn't affect vision of the patient,
Okay.
and generally diagnosed incidentally in our OPD.
Okay.
Yes.
So some of these cataracts are there. Some Christmas cataract. Have you
So
heard of
Christmas
that?
tree in myotonic dystrophy is present.
Yes, very good.
Polychromatic cluster is present in Christmas tree cataract, sir, seen in myotonic dystrophy.
These are some of the questions that I wanted to ask. Thank you so much.
Okay.
Very well presented.
Dr. Salhotra sir. Sir, you're muted.
Dr. Saurabh, very nice presentation. And this is one of the very rare cataracts which we see maybe once or twice in your lifetime. Not very commonly seen unless you are practicing in a multi-specialty hospital where you have all these systemic diseases. In the solo practices, or if just working as an ophthalmologist, you rarely see these cases. So any differential diagnosis, all you have mentioned, I have seen those lists. Any other differential diagnosis which you could think can lead to this type of a picture?
Sir, intraocular foreign body, intraocular copper foreign body when history of trauma with copper, sir, then Wilson's and sunflower cataract appearance is seen. But in that condition, sir, we can see intraocular foreign body by various modalities, and we can see chorioretinal scar on retina, and sir, foreign body will be visualized.
You will see if the foreign body touches the retina. If it doesn't touch the retina, and if it is lodged somewhere else, you will not see the scar, but the picture will be almost the same. So you have to rule out with other test modalities, you should rule out the intraocular foreign body, which is an important entity. And what is the treatment protocol you follow in an early stage? Do you think it is a reversible disease?
Yes, sir. Of course, sir. It is a reversible disease. K-F-ring disappears with the copper chelation therapy. Sir, previously we were using D-penicillamine, 1.5 to 2 milligram for per day dose for this disease. Later on, due to side effects seen from penicillamine, we moved on to trientine, and now we are using tetrathiomolybdate, which reduces the absorption of copper from the GI tract, as well as it also help in incorporation of copper in ceruloplasmin.
Okay. So if you see the KF rings, and what type of cataract you see in this type of patient? What type of cataract it is?
So it is sunflower cataract seen along with.
What is the location of the cataract?
So location of the cataract is subcapsular presence of.
So subcapsular. So if
it can be anterior or posterior, but
agreed. Most commonly it is anterior subcapsular. Posterior does happen not that frequently. Mainly it is interior subcapsular. Yeah. So in an early stage, if you treat these cases well, is it reversible?
Of course, sir. In early stage, if we treat the patient with chelating therapy, or in maintenance time with zinc acetate, sir, it will be reversible in very early stage. But later on, if deposition is lots more, then we have to plan for surgery ultimately.
So early stages, once you see the haze, if there is a haze, like you see the KF rings, if there is just the haze and you treat it properly by decoppering therapies, as you have rightly mentioned, then it is at a reversible stage. But if your lens fibers become opaque and you have rather than the just interior subcapsular fibers also get involved, then you have to go for the cataract surgery extraction, as you have already mentioned. Any particular precaution do you take for the surgery?
Sir, sir, for surgery, sir, we have to presence of KF ring is there in periphery. We have to be careful for that. We will do a proper capsulorhexis of sufficient size for the same.
So entry, you have to be careful of your entry, because sometimes there is a haze in the periphery from the corneal wound. So so your tunnel has to be very carefully made. Okay. And rest of the surgical steps almost remain the same as far as the subcapsular cataract or other type of cataracts is concerned. That is the only concern. Rather, they are very easy to handle, being the softer cataracts. So you can easily do away with the surgeries. So very nice presentation, and I would like to congratulate you. Thank you so much.
Thank you, sir.
So if there are no more questions, any more questions that you'd like to ask any of the examiners? Okay. So thank you, Dr. Saurabh. That was a very well worked up case, and I really compliment you on the depth of your preparation and the very crisp, precise, and accurate answers that you gave. So
thank you.
Very well done. Very well done. And I also compliment Dr. Amresh Kumar for his expert guidance of the mentee. And I think it was a very well worked up case. So Dr. Amresh, I invite you to, add something, give some tips to the presenters, to our PGs. Dr. Amresh?
Yeah. Good evening, everyone. So
any common mistakes that you would like to highlight that they make in the exams, or any tips that you would like to share?
So in exams, like generally the PGs, they become like quite nervous and all, and they start hurrying up in their presentation, which I ask my PGs to, like, you have to speak slowly and clearly, and whatever you speak, be confident in that. And while taking cases, I just ask them to go through each and every step particularly well, and so that you don't miss anything. Many a time, I think, like in case of like doing it quick, they make mistakes and miss points. But like I particularly took care that he doesn't miss any point, and that was all from my side. And there's not much, like I also has pointed out to him that these cataracts go away if we do like we treat the Wilson's disease at time. Like if the Wilson disease is treated on time, sometimes the cataract also disappear. So that was all. Yeah. Thank you.
Thank you. Thank you so much. So once again, I'd like to compliment and congratulate our very young presenters, Dr. Shikha and Dr. Saurabh, for their excellent presentations, and also congratulate Dr. Sujata Chahande and Dr. Amrish Kumar. And lastly, but not the least, a very big thank you to our examiners who, gave such excellent questions. There was a very good discussion on all the cases. So thank you so much, Dr. Sudhir Salotra, Dr. Shrikant, and Dr. Kamaljeet Singh for being here with us this evening. Thank you so much for your presence.
Thank you
And,
so much for
thank
the
you,
opportunity.
Thank you so much for giving me this opportunity to be with you and take part in this case presentation. It was a very good experience. I should thank ARC of AAOS and Dr. Bhavankule for Prashant Bhavankule for giving me this opportunity. Thank you so much, sir. Thank you. Thank you, Dr. Tinku. I have heard your name, but this is today only I saw you face to face.
Yes, thank you.
I would just like to add one more question that generally we ask in KF rings is which layer of the cornea you see it, and the other differential that you may have with the KF ring. So the rest of the questions, I think, because sometimes, they go to the real basic questions, the UG questions when we start off. So I think that is one more thing that I would have added. Yeah.
Saurabh, would you like to answer what
Yes, sir.
ma'am is asking? Yeah.
Yes, sir. Sir, it is extracellular deposit of copper in the descemet membrane, which is easily picked up on ASOCT. Hyperreflective descemet layer is seen.
I think all the PGs go to ASOCT so often. I mean, you need to go to the slit lamp first.
Yes.
That's the basic thing. You need to first examine.
We used to see on slit
lamp
lamp these type of things.
See,
now
not
OCT,
everyone is, the practices that you don't have the luxury of having an OCT at every setup. So slit lamp is the basic that you need to first resort to.
Actually, if it is very much marked, we can see even by a torchlight only we can pick out. But slit lamp is definitely diagnostic, easy to see. We don't have to rely on OCT for this.
We never had OCT. So
correct. Exactly.
Another question that is asked is that very early KF rings may not be seen, on the slit lamp. You'll have to do a gonioscopy to see very early KF
Yes, the gonioscopy is also used for the same, ma'am. In
right.
gonioscopy and in oblique slit lamp examination, KF ring is picked up.
Yeah, those were some very important tips that we got from the examiners and the other people. Any other parting comments, any tips for our PGs? Most welcome to point out the examiners if you'd like to add something.
Just one thing, Dr. Tikku.
Yes, sir. Sure, sir. Go ahead, please.
Just one thing that we get, usually we give cases, common cases for PG examination. So that is important. You should keep on seeing the cases and presenting as these two presenters have done wonderfully well. And if you keep on presenting, your half battle is won. So you don't need to worry about this. Only thing is that this presentation should be a regular phenomena in the departments. So that is what I wanted to say. Thank you so much. Very well presented, both of you.
Thank you. So thanks everyone, and thank you to the audience who's logged in to watch. So next Thursday we have another another episode of PG teaching program. So I request all the PGs to log in again same time next Thursday. So we'll see you again. Thank you so much, everyone. It's been a great discussion, and thank you all for being here with us. Thank you.
Thank you, ma'am. Thank you.
Thank you.